Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Dose Intensification in Early Unfavorable Hodgkin Lymphoma, Final Analysis of the German Hodgkin Study Group HD14 trial by Von Tresco and colleagues from the German Hodgkin Study Group. My name is Jim Armitage, and I am the Joe Shapiro Professor of Medicine at the University of Nebraska Medical Center, which is in Omaha, Nebraska. My particular interest in oncology is the management of patients with lymphoma. The title of this is Early Stage Hodgkin Lymphoma, How Much is Enough? Hodgkin lymphoma is now curable in 80% or more of all patients, and in 90% of those patients who present with limited stage disease, meaning Ann Arbor stage 1 or 2. The first patients cured from Hodgkin lymphoma were treated with radiotherapy alone in the mid-20th century. However, it was not until the widespread use of the MOP regimen that followed its original report in the literature in 1970 that there was a dramatic decline in the mortality rate from Hodgkin lymphoma in the United States. However, chemotherapy regimens were initially utilized in patients with advanced stage Hodgkin lymphoma or in those with limited stage disease who had failed radiotherapy. Today, chemotherapy is the primary treatment for almost all patients with Hodgkin lymphoma, and for patients with limited stage disease, radiotherapy is often administered adjunctively. There is currently a debate about whether patients would be better treated for early stage Hodgkin lymphoma with chemotherapy alone, at least for those who rapidly achieve a complete remission. It has been known for some time that patients with limited stage Hodgkin lymphoma can be subdivided into favorable and unfavorable subgroups based on the presence or absence of a variety of risk factors. The German Hodgkin Study Group identifies unfavorable patients as those who have a bulky mediastinal mass, extranodal involvement, an erythrocyte sedimentation rate of more than 50 when the patient does not have B symptoms or greater than 30 when the patient does have B symptoms, or those patients with 3 or more lymph node areas involved by lymphoma. Some studies would lump patients with stage 2B Hodgkin lymphoma with those who have advanced stage disease. But such patients, if they had a high sedimentation rate or multiple sites of lymphatic involvement, were included in the study. The German Hodgkin Study Group has also included both classical Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma in their studies, although 95% or more of all patients typically have classical Hodgkin lymphoma. This was presumably the case in this study, where almost 89% of the patients had either nodular sclerosis or mixed cellularity, classical Hodgkin lymphoma. As is true for advanced stage Hodgkin lymphoma, the intensity of treatment of patients with early stage disease has been controversial, trying to balance between the highest possible cure rate and toxicity. In patients with early stage Hodgkin lymphoma, long-term toxicity is of particular concern, since these are often young patients with a very high cure rate from their lymphoma. In studies from years past, using higher doses of radiotherapy and older radiotherapy techniques, the death rate from second malignancies in cardiovascular disease, usually occurring 10 to 30 years after treatment, often exceeded that of those of deaths from the lymphoma. The study by Von Tresco et al., that is the subject of this podcast, tested 4 cycles of ABVD versus 2 cycles of Biacop followed by 2 cycles of ABVD. Patients in both groups then received 30 gray of involved field radiotherapy. As might be expected, there was more acute toxicity, but less relapses in the arm that included the Biacop. However, the overall survival was identical in both arms. This reflects the ability of autotransplantation to rescue patients who fail ABVD. With advanced stage Hodgkin lymphoma, in patients who have failed 6 or 8 cycles of Biacop, few patients are able to be rescued with autotransplants. However, there were several patients successfully salvaged in the Biacop arm in this study, presumably some after undergoing transplantation. So we are left with a dilemma. First, is it worth the increased toxicity of Biacop to make salvage therapy unnecessary in 1 in 16 patients? If you are an oncologist who has never used Biacop, but believe that this would be a worthwhile goal, remember that Biacop is a very intensive regimen that is not simple to deliver and has a learning curve to be facile in its use. Second, it is likely that PET scanning after 2 to 4 cycles of therapy with ABVD would identify those patients likely to be cured without needing the increased dose intensity of Biacop, and perhaps not needing radiotherapy. Third, is the radiotherapy really necessary in the Biacop arm, particularly if the patients achieve a negative PET scan? And finally, the median follow-up of this study at the time of the report was 43 months. This is certainly long enough to get a clear idea of the rate of durable remissions achieved in the 2 arms. It is not nearly long enough to know if there is going to be increased late toxicity and mortality in the Biacop arm because of the more intensive chemotherapy, or in the ABVD arm because of the more frequent requirements for salvage therapy. So, as is often true in our profession, as we learn more questions become apparent. Fortunately, for patients with early-stage Hodgkin lymphoma, we are fine-tuning a treatment that can cure more than 9 out of 10 patients. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.